are there safe areas to pass wires? Now we're passing these wires blindly. There are no safe areas in the hand. So what we have done in the past is to pass wires like we would pass for fractures in different places, for fixators in different places, and we proceeded to remove all the skin and see what all were pierced. And obviously, we knew what was going to be pierced. We were stupid to do these tests and examinations, but we did it to see what was being affected. We did not have fresh cadavers, otherwise we would know what movements were being affected. But we didn't have that, so we did this on old cadavers, meaning the dry cadavers, and we got a fair idea of where we were going wrong and how we could improve. But there are no safe areas. So we pierce through these structures, and therefore we need to take into account the Elizarov principles of stretching tissues to their maximum when you're impaling them towards the bone, so that they're not impaled in their shortened position. And that's such a beautiful tenet. Once you use that, most of these fractures will do well. The other question is, aren't threaded pins better? Well, there are no added advantages, and there's a study that's a very old study by Roy, Kaba, and Meals, I think, that less than 2 millimeters, the pull-out strengths are not significantly different. So therefore, I don't use that. The second thing is that soft tissues can get wound up on the threads, and unwinding with a K wire is possible, but with a threaded pin, it will walk out. So it's not a good idea, like here. So you see the K wire where the skin is gone through the skin, there's no winding up of the skin, but where the threaded pin goes in, it can wind up the skin. And I've done this with an idea to show what happens inside. So interossei, extensor tendons, if it's a threaded pin with large threads, it can cause this. So if you want to undo this, you'll turn it back. And when you turn it back, the screw will walk out. So we've done a lot of K wires over the years, and we don't have too many regrets. The short trocar tip is the best because you want the wire to go across. And if you see on the right side, where the yellow part and where the points of these wires go out, when the full point goes out, only then does the wire fill up the hole. So the stability increases when the whole wire is within that hole. Therefore, the shortest trocar tip. Otherwise, beyond that, the soft tissues in the hand are there. So you're going to be impaling something. So be very watchful about this and use very specific stainless steel wires, which are 316 LVM or vacuum remelted stainless steel wires. They're very strong wires. So done well, wire failures are rare. And this is a patient who came to me after 8 years of the fixator was applied. For 8 years, he used the fixator as an excuse to stay out of jail. What was interesting was the terminal part, of course, because of the FPL, you can see that bone has been eaten up and the wires come out. But look at the proximal part. Amazing. This man is mentally unstable, doesn't take good care of his cleanliness, and yet these wires have stood there for 8 years with no reaction. That's fabulous. And that tells me that we're not doing too many wrong things. Let's now look at intra-articular fractures. Most important thing is to identify what you're looking at and understand the importance of it. The next thing is to restore the anatomy, ensure the stability, and as we've spoken earlier, start mobilization right away at the earliest, not more than 2 weeks. So sometimes we might impale a joint and fix it down till it gets a little gluey or sticky, but after that you've got to mobilize. And don't forget, when you're dealing with intra-articular fractures, long-term splintage exercises is the mantra. Classifications, many classifications, but this to me gives me a wonderful idea of what I'm dealing with. So there could be an extra-articular fracture close to a joint which can mimic a joint fracture, or there can be a partial articular fracture with depression or not, or there could be a complete articular fracture where the metaphysis also could be impaled, could be fractured, or the entire articular surface is completely smashed to smithereens. So these are simple things to look at, no need for numbers, and it gives you an idea of what structures are stable and what are not, and what you need to do surgically. So we'll look at that. When you're dealing with intra-articular wires, you must at least have 1 millimeter, 0.8 and 0.6 millimeter Kirschner wires. Without this, you're playing with fire because large fragments, large wires and small fragments, completely wrong idea. Try and use a wire driver or be very good with your drill and have a firm grip on your drill so that you don't wobble too much. You must have a sharp, small wire cutter. Now, if you don't stabilize this, now it looks like it's in a straight line and you don't need to fix it, etc. But you know that it's going to slip off. The moment it starts flexing, it's going to slip off. And that is why you need to fix it down with two 1 millimeter or thinner K wires, and you can get it. Sometimes the condyle just doesn't slip off, it flips over. So this is turned over, the articular surface is looking to the other side, and this cannot be treated closed. So you need to open this. When you need to open this, you're looking at the condyle. So where do you want to go? You want to go there. So you can go into that interval. Don't go from the dorsum. You want to be on the side where you can actually lift up this little screen and look at your bone fragment directly. Once you do that, you can fix it down. Doesn't matter whether you're fixing it down with screws, you can fix it down with two thin K wires, 0.6 millimeters, 0.8 millimeters, perfect wires, and you can get excellent function from this. You can use screws, obviously, screws will suffice. Sometimes one screw is good enough, but you need to capture both cortices, and only then are you going to get it. And you need the proper size of screw, and you need to know from where to go. Where do we pass these screws from? You need to pull back the collateral ligament if you want to pass it distally in the head, or if you want it to be a little more proximal, you need to go between the collateral and the accessory collateral, so you need to know where that is. Or if it's much more proximal, then you need to go in beyond the collateral ligaments. That means more proximal to it. So these are the 3 points from where you can actually pass in a small screw, which may not affect the function of that joint. So be careful where you pass your screws from. Don't impale the collateral ligaments. Don't fix down the collateral ligaments. Here we've seen unicondylar fractures. Now here's a bicondylar fracture. Here's a bicondylar fracture which is split open and slid down forward. So you need to fix this down. So you pass two K wires. These are too thick. This was a time when I did not have smaller and thinner wires. Today, without the thinner wires, we wouldn't even start the surgery because they are available with various companies, including Indian companies. But even then, you're able to get a good reduction and great healing with almost near normal function. Sometimes the two condyles not only move apart, they also flip on both sides. And this is, again, an injury where you're stuck with what am I going to use? So you think, maybe I can fix it down with wires. So you go in and you get the two condyles together first, then fix the two condyles to the main fragment and add one extra wire if you need that. It looks like a large number of wires. There are 4 wires here. You can see there's a fracture in the middle phalanx articular surface as well, but it's congruent and it hasn't moved away. So it is in its position. So you start early mobilization. You could use newer plates that are designed to allow you to go to that area under the extensor tendon, but you should be very careful because otherwise you could cause a lot of stiffness. So here's the patient once he was healed, once she was healed, and that's the range of movements that she's got. So it's an absolutely wonderful technique. If you got everything in place and you started early movements, you will get great results. There's the other fracture which was thought to be a very minor fracture. It was reported as being mildly displaced fracture, but in the operating room you realize what's happening. You see the condyle is knocked over. It's a disaster. So you need to go in from the volar aspect, you need to fix it down, maybe with 1 or 2 screws, and you can get a fairly good result in these cases. Just because you have implants, don't use wrong implants. So here's a headless screw. I think the surgeon was headless, not the screw. You don't use implants like this within a joint. It's not going to work. And look where on the dorsum what is happening. We're now quickly going to go to the PIP joint, which normally can be hyperextended, where there's a small fragment below, or you can have a small part of the fragment going along with the middle phalanx. This is the commonest injury that you see, and at times you'll find that it is very, very unstable if the articular surface involved is more than 30 or 40%. So there's this tenuous and stable and unstable kind of theories that are there, but I think you have to take each case on its merit, and I'll show you why. The first thing to know is that you need to see a proper lateral view. So you need to get a full proper lateral view, else you're not going to be able to assess this fracture. look for what is known as the V sign. So there is this instability there where the middle phalanx is moved up, and that is called the V sign. So when you have a V sign and you try to flex, this is what happens. You can see on the right side that the sharp portion of the fractured area in the middle phalanx will come in contact with the head, and it will start causing arthritis and pain in that region. You get hinged pseudoflexion at that point. You need to reduce it and give an extension block. Don't allow extension because that is unstable. So you hold it down in flexion. This is the simplest way of doing it. It's a little too heavy, but it does a great job, gives you good results. This is an old slide, 1993. This is what we did then. More recently, this is what we do. Here's a patient who's got the same kind of a fracture with a V sign quite clearly seen, and unfortunately the ring is not removed. So remember one thing, first remove the ring before you even talk to the patient. By the time you finish talking, the ring may not come out, you may need to cut it out. So a ring block has been given and a reduction has been effected. So now what you see is it's a very congruent reduction. You check the stability. The articular surface will not now poke into the proximal phalanx, but it will glide along this. There's no crepitus, there's less pain, and there's good movements, and this one can be taken up for conservative treatment. Now, if you go by the textbook advice, that this is much more than 40% of the articular surface, and this deserves a fixation, but you can treat this conservatively. Where do you go wrong? You go wrong when this is your flexion. So if you see on the right side the flexion, that is what is hinged pseudoflexion with point loading on the proximal phalangeal head, and there is no gliding. But if you get, so this is not to be done, but if you get stable in this position, then you can treat it like this, where an extension block splint is given only to the two fingers that are being involved. That is one and its adjacent finger. The other fingers are kept free for function, and he goes on to heal. That's the same patient who had that almost 40% problem, and this is a very good smooth range of painless movement. So conservative treatment works in intra-articular fractures if you know what you're doing and if you achieve what you want. If you know all of this, then you're going to get it good. The other technique which I used to use many years ago when I was working with Dr. Joshi was one of these techniques of having a wire frame to hold the traction and keep it back in place. But we eventually gave that up because we're doing them differently now. We do them open and fix them down more often than we use these wire frames. The wire frames are indeed successful, but are difficult to manage. And I find that there's an unusual amount of pin track infections in the cases that we did earlier. This is an innocuous looking fracture, but when you take the lateral view, you realize what's going on. Even the DIP joint is unstable, and the PIP joint has a large, unstable fragment with a V sign. So you can fix this because there's a large fragment. You use 1 millimeter screws, you flush them down onto the bone, and you can get a good articular surface, and you can get an excellent result in these. So here's another such fracture with a long oblique with a big fragment there. And what you also notice is a significantly impacted fragment. So now you've got a simple one, you've got one with an impacted fragment. When you have an impacted fragment, that has to come out, that has to be elevated. There are different ways in which you can do this. There are different windows with which you can go in and open this and bring this out. There's some need for bone grafting in some of these cases, but in this particular case, I just needed to bring it back into place, put in a few screws, and get an excellent function. What about late presentations? What can be done now? So here's a patient who had a V sign, and over a period of time he became stiff. So what we did was we opened the A3 pulley, went in, took down the volar plate, excised that fragment, and advanced the volar plate with a pull-out stitch on the back. As you can be seen on the left side, you can see the proline sutures there, and the patient gets a fair degree of movements with this. The other way that you can do this similar case is to use anchors. So you can use bone anchors to try and pull up the volar plate back into its place and get a very good result. So in a late presentation, you can do a volar plate advancement either with a pull-out suture or with an anchor into the bone. The anchor costs a little money, so you'll need to be you need to be aware of that. And this is what it looks like. So it's not correcting anything, but it's interposing some tissue in between, which allows a fair degree of movement. And that degree of movement is around 68 degrees that has been calculated way back by Eaton et al. What else is possible, and what is the current way in which I would treat these? Here's a patient who had the V sign very clear with a small thin fragment. The surgeon tried to reduce without anesthesia, got the hinged reduction there. Then with anesthesia, he managed to get it in, but then he said, no, I'm not very happy. So he put an external fixator from the dorsal aspect. Big mistake. Don't do this. You put in pins through the extensor tendon. We're trying to avoid that. But here's the surgeon who did that, and he was satisfied with this. But at 12 weeks, the patient comes like this to me. The V sign is still there. And therefore, one of the indications that I have is for chronic injuries. And if the articular surface is a large piece that is gone, then I would think in terms of doing what is known as a hemi-hamate arthroplasty. So we open this, and this is how it looks. It's not reconstructible. The proximal cartilage, the proximal phalanx cartilage on the right side, you can see is unaffected. So it's a good joint that needs a matching joint on the opposite side. The matching joint comes from the hamate. You need good instruments, implants, and skill for this. So here's that patient with that injury with no movements at the PIP joint, and there's a slight flexion at the DIP joint. So you take a Brunner incision, you open that out. Once you dissect that out, you see the pulleys there. You open the A3 pulley like this. So you can see below, proximally you can see the A2 pulley, and distally you can see the A4 pulley. So the entire A3 pulley is opened out. And when you flip it over, you can see the flexor tendons. On the sides, you can see the neurovascular bundles on both sides quite clearly. And they are protected by a nice layer of fat there. So you need to know where to go. Once you do that, then you cut the collateral ligaments, at least partially. And this is then flip the joint open. And it's called a shotgun approach. And when you flip the joint open, this is what you're going to see. The joint is completely destroyed. There's no way it can move. There's going to be a lot of crepitus, and therefore you need a small piece of the hamate, which is at the base of the 4th and 5th metacarpal. And this is Hill Hastings at Davos, taking a wonderful class for students there. And he came up with this brilliant idea that the hamate looks like half of the hamate looks exactly like the volar part of this bone. A lot of this work also was done by Zemel, where he used just bone grafts to create that little overhang of the proximal of the middle phalanx. But you need to be careful when you do this surgery. It requires great concentration, and we've made a lot of errors while doing these surgeries. You must remember these nerves, which are extremely difficult nerves. And once you get the hamate piece, you shape it like you can see on the right, fix it down with a screw. So now you've got a full joint that can look like a normal joint and function like one. So it's a great surgery. It's a simple surgery if you know what you're doing and if you understand why you're doing it. The results are excellent. You can get this kind of movements. That's almost 85 degrees of movement. What about these fractures? Well, some of these fractures are difficult. So what you do first is you give traction. You've got a pilon kind of fracture where the dorsum and the volar part are flipped. So you reduce the dorsal side, fix it down, and then I used, in this case, after doing the same approach, I used one of these plates, split it, broke it down, and had two small little hook created out of the ends, and used that as a hook plate to fix it down. Not a brilliant idea to have not fixed the dorsal part properly, because it tended to move away. And if I had not done that, the articular surface looks good. It would have been much better. But this patient has done extremely well. He's got 60, 70 degrees of painless movement and has started playing his sport again. Now, looking at metacarpal head fractures, Doesn't again look very, it looks very innocuous, but if you look carefully, you can see half the head is depressed. And if you get a CT scan, you can see that the metacarpal, the proximal phalanx is not going to flex on this. How do you approach this? It seems simple to approach it from the dorsum, which is what I did in first few cases, and I found that I couldn't see the proximal, the depressed portion. So how do I get to that? There you can see in the depth the small piece. So getting to that to bring it back out was such a big problem that I had to use bone levers to lever it up gently, bring it into place, hold it down, and fix it down and get this result. In a subsequent such case, then I started opening them from the volar side. It's always worrisome to open from the volar side, but it's fairly simple when you look at it. And when you do that, you're able to get this extremely easily, fix them down again with screws, and 3 years post-surgery, this fellow is back to a lot of sports. Now, this is a patient who's 6 weeks from a World Cup. She's she's a cricketer from the Indian team, and there are 6 weeks to the World Cup, and she was injured while practicing during the nets. And that's a badly comminuted fracture of the metacarpal head, and she is a key person to the team. So they just said, we don't care, we want it. So this is the answer to Tyre's question, that how soon do you send them back? Well, I don't want to send them back too soon because I'm going to recreate this. So this is the CT scan. We opened it from the volar side. We lifted off the volar plate from one side. We opened the capsule, reduced the fracture, and put in plates, put in a plate and screws, and I put in a couple of K wires. Now the question is, if I've done all of this, why the hell do I need K wires? And the reason is because, very simply, the length of the wires that you get sometimes are inadequate for the reach of these wires. And that's what happened in this case. I couldn't push the plate further up. It would come in the way of the function, and therefore I had to do that. She went on to be one of the key bowlers and got more than 10 wickets, I think, in Australia recently, where we lost the finals. And that is her function. Absolutely wonderful. And she, how soon did I send her back? Well, she had to join the team because of the COVID situation. So she joined the team early and she stayed. She practiced over there on the bus. She would send me videos, and the rehab, the physiotherapist was with her. And at 6 weeks, she entered the ground. So that's the earliest an intra-articular comminuted fracture of the head of the metacarpal can actually go on the field without pain. She strapped her finger quite heavily, but she did extremely well. So that's all there is about intra-articular fractures. There's so much more about intra-articular fractures, but I think I covered a fair chunk with some ideas about how to go about them.